Hello, and welcome to the Roseman University Roadrunner Resource Series. I'm Brenda Griego, Roseman's Alumni Director. I'm glad you can join us for tonight's presentation. In just a bit, we'll be hearing from Dr. Joe Greer and Dr. Luther Brewster, who will share some exciting thoughts about the focus and impact of Roseman's College of Medicine. But before I introduce them, I have three quick housekeeping items. First, this presentation is being recorded, and it will be posted on Roseman's YouTube channel in the coming days. We will email you that YouTube link when it's available, along with the PDF of tonight's slides. Second, following tonight's 45-minute presentation, there will be a 15-minute question and answer period. To submit a question, please click the Q&A icon at the bottom right of your screen. Drs. Greer and Brewster will respond to your questions in the order they were submitted. Third, this presentation is being sponsored by Clark County Credit Union. Clark County Credit Union is also a continuing sponsor of Roseman's Neighborhood Health Series. We are grateful for their generosity. Let's take a second to listen to a brief sponsor message from Clark County Credit Union right now.
Hello, everyone. My name is Craig Fraley. I'm the Director of Business Development for Clark County Credit Union. As the credit union for the medical field, we are very happy to sponsor Roseman's Neighborhood Health Series. If you should ever need financial services, you can reach us at ccculv.org or call us at 702-228-2228. We're not-for-profit, owned by our members, and we give our profits back in the form of bonus dividends every year. Thank you, and have a wonderful time at the presentation.
Fabulous. And now it's my pleasure to introduce Dr. Pedro Joe Greer and Dr. Luther Brewster. Dr. Greer has had a distinguished career in medical practice and in academic medicine, including helping to found Florida International University Herbert Wertheim College of Medicine in Miami, Florida. Working with various FIU colleges, Dr. Greer spearheaded the nationally recognized Green Family Foundation Neighborhood Health Education Learning Program, Neighborhood Help. Dr. Greer's list of accomplishments is incredibly vast, so I will note just two highlights that themselves are revealing. In 2009, Dr. Greer received the Presidential Medal of Freedom from President Barack Obama, and in 1993, he was honored as a MacArthur Foundation Genius Grant Fellow. Dr. Brewster also joined Roseman from Florida International University, where he was founding chief of the Division of Policy, Research, and Community Development, the community director of the Green Family Foundation Neighborhood Help, and associate professor of medicine and society. Dr. Brewster's awards are also extensive, so I will again cite just a few. In July of 2010, Dr. Brewster was a recipient of the Marshall Memorial Fellowship through the German Marshall Fund, which brings together Americans and Europeans to increase understanding and build transatlantic networks among the political, media, business, and nonprofit communities. And in 2015, Dr. Brewster was named the first public member of the Thoracic Surgery Review Committee for the Accreditation Council for Graduate Medical Education. Again, these two leaders are incredibly accomplished and encourage you to learn more about them at medicine.roseman.edu. And now, take it away, Dr. Greer.
Brenda, thank you so much. And I want you to know that my mother wrote that introduction. So, well, welcome. Dr. Brewster and myself are thrilled to be here. And when I say here, I mean at Roseman. And we want to give a brief overview of what we want to do. And in other words, this is the appetizer with our flagship program. And I also want to give out a big, giant thank you to the Clark County Credit Union, not just for your support, but what you do as an institution. Let me start off with the mission that we have at the medical school: to align students, educators, and community in designing and delivering an inclusive and collaborative environment for innovative learning, healthcare, and research. And then as I go through there and introduce our senior team, I want you to know that what we'll be presenting to you is Genesis, our household-centered care model, which is experiential interprofessional medical curriculum, healthcare delivery approach, and a population health strategy aimed at moving towards the vision of Roseman University College of Medicine. What we plan to do here as an institution and part of this great University of Roseman is not just produce the future healthcare workforce of of our communities and of this country, but prepare them in a way that they are ready for all the changes that are impending in medicine, things that we have seen and have been accelerated because of COVID. We will be emphasizing clinical excellence, ethics, empathy, critical and creative thinking, and real world experience, so our physicians come out as the most humble servants that are to improve the health of all societies. We want to lead the state, we want to lead the region in creating technological strategies to achieve academic excellence and advance effective and inclusive healthcare delivery systems. We don't want to be measured just on how many successful physicians we graduate, but we want to be measured also on how we improve the health of our region. Let me introduce you to our team. We have Dr. Cheryl Brewster. She is a Senior Executive Dean of Diversity, Equity, and Inclusion who comes to us with an incredible background and did this also at FIU. Most of us here that came out here were also founding faculty at the FIU College of Medicine. She started a STAR program at the Florida International University that brought in a pipeline of students, as we are doing here as we work with the state institutions, the College of Southern Nevada, Nevada State, and UNLV, to bring in students, first-generation students, to diversify the workforce. And as you will see, the leadership is as diverse as the student body we wish to have. Dr. Luther Brewster, who you will hear from in a little while, he did his postdocs at the University of London, as did Dr. Cheryl Brewster, who also was in the private industry, where he led in economic and community development in Harlem, Detroit, and Atlanta. He is the architect behind this household-centered care, and he will be explaining exactly how that works. Dr. Karen Esposito, she is an MD and a PhD and a Senior Executive Dean of Academic and Student Affairs. She led the Office of Medical Education at our prior institution, as well as being the Senior Executive Dean for Student Affairs. There, we took 70 to 75% of our students only got into FIU. As a new startup school, a lot of times the students that get into established medical schools will take those acceptances. However, she managed, with the team that we have here, to be able to lead these students in every single graduating class we have had since 2013. In Miami, they have had the highest step scores, the highest pass rates, and the highest match rate in the entire state of Florida, which is pretty good for a startup school. Once again, emphasizing the importance of ethics, critical thinking, and creative thinking, we have Dr. Maren Gillis. She is a philosopher, a bioethicist who happens to chair the Cambridge Consortium for Bioethics, who is our Senior Executive Dean for Faculty Affairs and Learning Innovations. We will be implementing new and different ways of educating medical students, including design studio teaching and hackathons, because of the complexity of the world that exists out there. And no longer can a physician just be aimed at a disease and forget everything else that goes around that organ, that body, and that household. We have Dr. Christina Conley, who is our CFO. In reality, she's probably the CEO too. She is a Senior Executive Dean for Finance and Operation, and she keeps us alive. And then we have Jamie Faircloth, who comes to us from FIU also, who is our Associate Dean of Assessment and Evaluation, because science is so vitally important, and you have to have measurements, you have to have evaluation, and we need to measure ourselves to make sure we are successful. By the way, she's the only member of the senior team who happens to be Mensa. Then we have Vicki Van Meeteren, who is a special advisor to myself. This is a nurse who has also been the CEO of various hospitals here in town, and has been advising us as well as helping us out in business planning for the entire aspect. And as you can see, the three words that we want to represent is humility, excellence, and respect. And that acronym spells HER. Why is Genesis needed? Well, when I went to medical school, and I'm a hepatologist, gastroenterologist by formal training, we were taught diseases. We were taught the microscopic aspect of it. Now it even goes even further. But the reality is, what causes this diseases? No longer is the cause of your disease your genetic code. It happens to be your zip code. And we have seen this with COVID, with the disproportionate numbers of those, particularly people of color and of lower socioeconomic economic regions, have a disproportionate number of infections and deaths. It is well documented in the literature that 70 to 80% of all health outcomes are attributable to non-biologic factors. We refer to those as the social determinants of health or the social determinants of inequality. I'm going to now turn this over to Dr. Luther Brewster, who is the architect of the household-centered care, as to how we plan to approach these things in training our future workforce. Lou?
Yes, good evening. So there is a lot that can be said about what the College of Medicine ambitions to do. But I think the core thing that we would like for people to understand is that the center of everything that we plan to do is the household. And why is the household so important? Well, in our eyes, the smallest unit of care should be the household, because when you are providing medical care to a patient, oftentimes, whether it's overt or hidden, there is a negotiation that goes on between that patient and the people that they love at home. For example, it may be the clinically appropriate way to prescribe a medication that may cost that household $100 after its deductible or its copayment. But that $100 could mean everything to the food budget in that household. And so when we are quick to say that an individual is non-compliant simply because they don't get their medications, there may be an underlying social phenomena going on that we're unaware of because we simply focus almost exclusively on the clinical aspect of that individual and exclusively on only that individual. So Genesis is about kind of changing that paradigm and kind of turning it on its ear. What would it be? What would it look like if for the first time you were able to ask a comprehensive questions about not only that patient, but the household that they come from, the individuals in that household? What types of things are negatively and positively impacting all members of the household that they live in? What about the physical structure? What about the employment opportunities, the educational attainment, the way in which they make their way around town, their transportation opportunities? All of these things will play a critical role in the way in which they utilize healthcare. And so if we know these things and they make common sense, then there should be a common sense solution for responding to them. And that's where Genesis kind of collides with this phenomena that I just described. Our work is done when we have assisted households in mitigating those social phenomena, those social risks that I just described. And we do that through a number of ways, but the most important one is that we believe that in tapping into the most underutilized resource in communities, and that is of these students, particularly professional students, who can play a critical role in helping us in doing outreach to these households that are at risk. And so we plan to assign these households to a practice group that is run and managed by a team of interprofessional students. So a medical student, a nursing student, a dental student, a pharmacy student will operate as a team or collection of teams in our medical practices that are headquarters at our medical group, the Roseman Medical Group. And they will extend the care that is provided at the Roseman Medical Group directly to the household. They'll do a series of household visits, and they will be charged with improving not only the clinical outcomes or the medical needs of that household, but also the social needs of that household as well. They will be supported by a team of lay health workers or individuals from those communities who have been trained to address those social risks that exist within that household. All of these things together will be the, I guess, practical way, the experiential way that we will achieve many of the mission and vision statements that Dr. Greer had mentioned previously. In addition to being able to embed this thought process in students in the classroom, we plan to leverage this also through our healthcare delivery. So it doesn't make sense to simply teach our students about how to address the needs of a household if we have a medical group down the street that's not mirroring or modeling that same behavior. So this household-centered care approach will be beyond just our medical curriculum. It'll be the way in which we provide care even at the medical group at Valley Hospital. And so it will be powered by state-of-the-art technology. This technology was designed over a 7-year prototype process that we performed in our previous location. And now Roseman will reap the benefits of that time spent focusing on what is the best way to track social risk over time and address those needs in a strategic way using a combination of medical students, nursing students, pharmacy students, dental students, but also lay health workers and clinical faculty members who supervise their work. This platform that we will use will not only benefit the students that we work with, but it will also benefit those households that we go to work with. Our aim is to go and work with the most at-risk households. This is not a program or an initiative about doing the same old thing. We want to run towards the fire, as Dr. Greer often says. We want to work with the uninsured, the undocumented, medically underserved Native American population, rural and urban high-risk residents. These are oftentimes the groups that many times health systems feel outmatched in providing care to, simply a lot of times because they do not have a vehicle to go to for expertise in working with these populations. We've worked with these populations in this format for the past 15 years. We have developed a certain level of expertise that enables us to be a resource and a support to health systems locally. But in addition to that, we found a way to scale it so that it is a benefit to not just the number of households that our students are able to work with, but it is also can be a resource to health systems through a healthcare delivery model in which we pair our lay health worker instead with a nurse practitioner instead of a team of medical students and interprofessional students. And all of this workflow and all of these moving parts are coordinated by the Genesis operating system. This operating system will allow the teams to communicate seamlessly. It will allow them to track social risk. It will highlight their acuity levels and what level of risk they are encountering, both in a medical and social factors. It will also allow individuals to know if they're making progress with the household over time in both areas. But probably the most important part of it is that it will enable us to provide the greatest amount of benefit to the person with the greatest amount of need at a given time. And so that risk stratification embedded in a tool as individuals are moving out into communities in all different directions will create hopefully a harmonious solution to a problem that quite honestly is tormenting not just the Las Vegas area, but across the country. And so that is yet another thing that we hope to accomplish not only through Genesis, but through Roseman College of Medicine. We plan to create local impact that has global implications. This is an example of what that technology will look like, but don't not only focus on the technology of it, focus on the fact that it is a new way, a refreshing way of looking at how patient care should be consolidated. It's looking at how not only the individual is achieving their goals, but also the household. It's about prevention tools, and you'll see at the bottom, mechanisms for individuals to learn new skills related to health and wellness. We're just as much about population wellness as we are about patient and household care. There is a practical workflow behind all of this, and it starts from the moment that we get a referral of a household or a patient to our initiative Genesis. So one of the core things that will be a trademark of Genesis is that our recruitment of patients or our consolidation of patients will not only be through the front door of the Roseman Medical Group, but we will work with community organizations to find individuals before they are sick, but have social risk, to get them on a program and in a strategy that will hopefully prevent them from needing to go to costly emergency department visits, to untimely chronic disease crises. All of these things, if you believe that social risk leads to medical risk, it makes sense to get people early by working with people who work with social risk every day to identify those individuals and get resource to them early. Another part to that is that there are a myriad of incredible organizations that are already doing excellent work in mitigating social risk. We all hear the stories of the homeless providers, the individuals who are doing workforce development, the institutions that are working to improve access to quality education, improving high school graduation rates. So all of these will become partners in our version of healthcare for many ways. I want you to kind of view them as like our social specialists. And so when we have patients or households that have advanced social risk, we plan to refer them directly to these organizations. So as those organizations are referring us individuals with potential medical risk, we're referring back to them individuals with social risk. And so this symbiotic relationship we hope will serve to create not only benefit for the patient and the households, but it will create an improved sense of community between Roseman as an institution and the community at large. Another way to say that is it will build trust between Roseman as a university and the community at large, most specifically those communities that oftentimes have been ignored or underserved in the past. It will stake claim as Roseman being unique and distinct and what it can offer to communities above and beyond what is currently being provided. It is there that we hope to create Roseman as the single most prepared institution in the region to provide care to the most high-risk patients in the region. Another element of this innovation will be the Genesis Zone. Through a partnership with the Department of Social Services and the Innovation District, we plan to create a zone of coverage that will overlay with the Wi-Fi mesh system that is being deployed by the Innovation District to provide no-cost Wi-Fi service to low-income communities in downtown Las Vegas. We will operate our Genesis operating system over that platform to provide our web-based services directly to these households. It is a way of immediately dealing with one of the many social determinants of health or social risk that households encounter that keep them from being able to achieve their health goals, and that is of the digital divide. So once we implement this Genesis Zone, I want you to envision a day where not only are we providing the likes of telemedicine services, telelegal services, being able to have individuals chart their own progress, but then eventually we would like to move to a case where we would have connecting groups, digital connected groups within those communities that can work to empower one another and promote health and support for one another within that community in a digital age. And given the phenomena of COVID, this is the best time and the most needed time for individuals to get the support from one another, not only for physical needs, but for mental needs as well. The last thing I would say is that Genesis is not about making individuals in communities better at being poor. Genesis is about building resilience in patients and households so that when they encounter challenges in the future, social challenges, medical challenges in the future, they will be more prepared and more resilient to endure those challenges. We will know that we've achieved this goal because one key distinction in the way we deliver care and the way we track care is that we do not find success in our ability to get individuals connected to the social safety net. We define success as our ability to get individuals to a point of thriving, getting that individual who may have never finished high school to get their GED and to register in a 2-year school or into some type of skill development program. Getting that individual who was unable to get more than a low-paying job to move their way through the ranks and get a job that will secure them with medical and other benefits. All of these things will prevent us down the line or in the future from seeing this rebound effect that we see so often, where an individual receives services from food stamps or Social Security or other benefit programs. They lose those benefits and they are right back where they started when they originally assumed those benefits. Individuals should grow and develop over time. They should not lay stagnant or lay dependent on these services for the remainder of their lives. You don't want that for yourself, and we shouldn't want that for any other member of our community. So that said, I will stop there. I encourage everyone who has an interest in what I'm talking about, if you have a sense or belief that there's a need for these types of services and that individuals should have access to it, I would encourage you to go to our website, which is listed there, genesis.roseman.edu. There are a number of different ways you can support. Feel free to contact myself or Dr. Greer directly. That is why our info is there. And we're always looking for talent. We're always looking for support. And we look forward to hearing from you. Thank you.
Thank you, Luther. We plan not to be a community engaged medical school. We want to become a community dependent medical school. We want to be a part of every aspect of this communities that we live in and those that we're going to be serving. An example of what Lou was talking about is, as a physician, a patient comes to me. Maybe they have cirrhosis because of unchecked diabetes or insulin resistance, and they have a bad fatty liver. Well, to get them first off is a diet. So what does a doctor do? We'll hand them a diet, or we'll send them to diabetic teaching classes. The reality is, the issue isn't just the diet. If I were to give this individual a diet and they were uninsured working 3 jobs, do you think the family could afford 2 separate diets? But imagine if we go into the household and evaluate what is going on and see the risk to the other members. Now we can guide the family in an appropriate diet that will not only treat the cause of this man's liver disease, but at the same token, prevent these metabolic syndromes in the rest of the household. This is why it's important to do this. Now, the brilliance that Dr. Brewster brings to the table is being able, from his experience in both government, he worked for John Lewis for many, many years, to private industry, to academia. He didn't mention, but he was also a professor at the University of Michigan and a founding faculty member at the School of Public Health at Florida International University, as well as at the medical school, is that you have social services that look at the entire house. That's how you get benefits, SNAP benefits, et cetera. What do we as physicians do? We progress from looking at a disease to looking at the whole person. Now let's take another step further and look at that person's surrounding and all the other things that can affect it. I know as a gastroenterologist that easily 2/3 of my patients, if not higher, have some sort of stress, anxiety, behavioral health issue, which is causing their GI symptoms. It's not for me just to do an endoscopy on the patient, but to listen to them, and then to try and have a team that can help mitigate the different things that are going on. What we hope, as being real members of Las Vegas, is the expression here is what happens in Vegas stays in Vegas. Well, what happens in Vegas stays in Vegas. What happens at Roseman, we want the world to know. Brenda, we're ready for questions. Please feel free to go into the Q&A and write in your questions.
Fantastic.
I heard alumni were not shy people.
That is true. And thank you so much. That was absolutely fascinating. If anyone does have questions, do submit them now through the Q&A icon, and Drs. Greer and Brewster will respond. We do have one question already from an alumna, Dr. Bowman. And Dr. Bowman asks, how are social determinant of health surveys used in practice, and are they addressed by the staff? How are patients referred to community resources?
Let me start off by saying they generally are not addressed. They'll ask you the first time you come to see a doctor if you have a job. They're not going to ask you anymore. However, if your blood pressure gets checked when you go to the doctor, guess what? You'll get checked again. But I'm going to leave the rest of these answers to Dr. Brewster.
Yeah, so I think Dr. Greer raises a great point, right? I think in the past we have looked at the social condition of individuals as sort of a point in time phenomena that never changes. So if you go to your doctor's office and they ask you, what is your employment status, and you at the time are working, the likelihood that they will ask you that question again in the lifespan of your time working with that physician is not likely, unless there is some extreme physical condition that that question has been scripted to be asked. We're just different than that. We see the longitudinal tracking of social phenomena as important to the care of the entire person. To answer your question about who provides those services, it's a combination. The first line of care in that is the lay health worker. Those individuals, and I hope to hire individuals who have less than a college degree, to come work with us, to go along and help in the recruitment of the households we'll work with, to provide frontline service, social service support for those households. And so you may ask yourself, well, why individuals without a college degree? Well, it's not enough just provide social assistance to the homes you go to. The first order of care and help that you should always provide is to those individuals that work for you and with you each day. It does not make sense to go out into the world and help everyone and ignore the person who's standing at your side. And so that's why we go that path. Individuals with a college degree many times in these areas ultimately will be fine. The data and the evidence has demonstrated that over time. But those individuals lacking a college degree, oftentimes not even completing high school, those are the individuals that we see disproportionately experiencing the burden of the health disparities and other disparities. We will lean on the great work of social service organizations in the community to provide advanced services to those individuals, and those services will be coordinated by our lay health workers, by their ability to go into our information technology platform, Genesis operating system, where they will find the information to connect that patient or that household to that resource. All of that is embedded in the platform for them to see. One key point that I left out about this operating system is that operating system also interfaces with the electronic health record. So what this means for the patient is that in a glance view, your doctor at Roseman Medical Group will be able to know whether or not those services, those social needs are being addressed and are indeed not complicating or creating increased complications to their clinical care. And that's very important. It's two teams working harmoniously together in partnership in tandem with the social service providers who are already doing great work out in the community.
Excellent point, Luther, because what ends up happening too is we tend to work in society in silos and in isolation. But to really address the most pressing problems, and in this country we have it, in 2017, Ann Case, a Princeton economist who does morbidity and mortality studies in this country, show that for the first time since the pandemic of 1917, almost 100 years to 1918, morbidity and mortality was increasing in the United States of America. No other industrialized nation was having that phenomena. When she broke down the cohorts, and the paper was entitled Deaths of Despair, and she broke this down, what the leading causes of this deaths were mostly non-Hispanic whites that did not go beyond a high school education. They were mostly of the baby boomer generation. And when you broke the cohorts down to their date of birth, the three leading causes of death that were soaring through the roof in this population were suicide, opioid overdose, and alcoholic liver disease, all caused by social factors that led to behavioral health problems that were untreated. So we'll be addressing not just physical health, social health, but also the behavioral health. And these are issues that are big in this country and big in any area. And we've seen this explode during COVID. The importance of doing this is there's a problem in our country. There's a problem in our communities. And these are the type of physicians we want to produce, those that are socially accountable to what is going on in their own communities, those that will help address issues early. Now, how did we come across with this? Well, having taken care of private patients and starting my career with homeless clinics and clinics for the undocumented back in the early 1980s, one of the things I was seeing was in the population that was insured that would come to see me, most of these social determinants were taken care of. I could deal purely with the disease state and I could educate them and the family. But in these clinics that we were running, we became Band-Aids. And I felt the futility of taking all these years of training I had and not really being able to help somebody the way I should. So there was a systemic problem. There was a training problem in the way that I was trained, and we wanted to do it differently. We want Roseman to be the example where people come to us and say, how do you do this type of education? How is it that you get these results that you do? In our past institution, of the 8 medical schools in the state of Florida, we were the only school that received recurrent funding from the state, from the Department of Health. And the reason was, by approaching the problem the way we do and the ingenious design that Lou has brought forward, we never even thought of this at the beginning. Maybe he did, I didn't. But we got an incredible return on investment. We were giving the state a 1,637% return on every dollar they gave us by being able to keep patients out of the ED, out of different institutions, keeping them healthy, allowing them to go to work, allowing them to pay taxes, allowing them the stability in the household. So the kids that were in that household then had a much higher rate of completing school, graduating, and increasing their earning potential.
Fantastic.
I think that the thing that we usually hear is so funny. It's like Groundhog Day because we were in this seat several, I guess 14 years ago, right? So talking about a similar thing. And at that time, everyone thought we were crazy. They were like, there's no way you're going to do this. And now, you know, we flash forward and, you know, we're here. And we have probably an even bolder ambition out here. And it's interesting, you know, the thing that I always think about when that question is posed as far as, you know, how are you really going to make this happen is, does it need to happen? Right? I mean, if you know, no one ever really asked that part, right? Does it need to happen? Do you need a genesis as it relates to the services for the people that we see? One thing, you know, that's it's eerily similar to when we started before. When we started before, there was a housing crisis. First couple of months of doing the program there, we had individuals being put out on the street weekly. Here we arrive and COVID is the issue of the day. And I remember Dr. Greer saying to me, you know, wow, it's like we're in the same position all over again. But the thing is that it's the need, right? The need is what makes you rush towards this without worrying about the if. There is no if, it's the when. When we help these individuals, that will make it all worthwhile. And it's kind of cool because Roseman has a history and a reputation of putting out an extremely high level talent in the area of healthcare. And one of the chief challenges we're going to have is our need for talent in healthcare. And so I would make an appeal to the alumni to consider and keep track of what we're doing and come home to Roseman to come help us in this endeavor, help us educate the students in the health workforce of the future, help us help households that truly need the help. These are the opportunities that something like a new medical school within Roseman can bring, not only for the community, but directly to our alumni.
As well as one of the things the reason we put our cell phones and our emails when we ended the last slide, and you'll get this in the package of slides that you get when you registered for this, is that we need your advice. What other ideas do you have that we need to be able to educate the future workforce? How do we need to do it? What do you think? Because all of these things, we are open to all these ideas. We want to create something different. One of the great advantages to coming out here to Las Vegas was we're not weighed down by the anchors of tradition that you find on the East Coast. There's free flowing of ideas here. There's equal challenges, and maybe higher challenges or maybe less challenges, but nonetheless, this is a need. This is our community. This is our state. This is our country. Let's be the example for the rest of the world.
Wonderful, wonderful. You touched on this a little bit briefly, but I'd just like to ask, and perhaps you'd like to elaborate more, how did you come up with this concept?
Well, it was interesting. Lou and I came from two different perspectives. One of the things when we were starting the Florida International University School of Medicine was we wanted to be different than other communities. The other medical schools. If we went into a community, we were going to stay there in perpetuity. Why is that? Because communities at risk tend not to trust anchor institutions, and particularly academic institutions. Why is that? Because we love to do studies. We'll take your blood, we'll take your history, we'll take your tissue. What do we give you back? We'll do a health fair. That doesn't count. Just to let you know how your cholesterol is high and your blood pressure is up. We need to go in there and build trust to be part of these communities. We're not going to go in these communities as the big giant institution. We're going to be brokers to bring these different organizations together. In Miami, we had 164 partners, anywhere from a mom and pop shop to a NGO, to a not-for-profit, to faith-based organizations. The idea was, let's make this community work together. Let's not be always fighting for that little dollar. When we're working with these different community groups, guess what? We'll help them write grants. Not only that, they can utilize the services that we offer as in-kind and show how they're working collaboratively so they could be funded also. Every single community organization we'll be working with is essential for this community. But at the same token, it's a chain link. And if one breaks, the whole thing can fall apart. And we're part of all this. And the other thing was, Lou and I asked the question, how do we get to the poorest patient before they get sick? Because as a physician, you wait for them to walk in. And if you're working 2 or 3 jobs, guess what? Every day you take off work to go see a doctor, you make 20% less because you don't have insurance, you don't have benefits. That doesn't include the cost of transportation, or the cost of the visit, or the cost of the test that the doctor's going to order, or the prescriptions. So you're asking somebody, if they're the head of that household, to sacrifice the rest of the household for their health care. It's easy for us to say, well, why didn't you get your mammogram? Why haven't you gotten your colonoscopy? But you know what? Maybe it's because they have other pressing issues like maintaining the ability to pay their rent, put food on the table. All of these different things are going on, and they go through things that we don't. If you have a job or 2 jobs and you don't have benefits, chances are you don't have a credit card. If you don't have a credit card and your card breaks on the way to work, you can't get an Uber. So we're here to try and link all these different complex issues that occur there and then train our future workforce to understand that. And particularly if they want to get paid, because we're going into a value-based reimbursement already by CMS. If you have a patient in the hospital with a certain disease and they're readmitted within 30 days, nobody gets paid. So you increase the cost of healthcare in this country, which we don't need to do. They recommend that a patient that's in the hospital have an appointment with a doctor within 48 hours. But if you're in the hospital for diabetes out of control for 3 days and we control it, that's 3 days without working. And do you really think they're going to take a day off in 2 days after getting out to do that, whereas we can deliver household-centered care? The idea is to get individuals, as Lou says, and their whole households to resilience. That's what we want to do. And we want to bring in first-generation college students from the area. We're going to have a master's program for a master's in science. So we've been working hard to be able to make sure that as part of this community, we're always servants of this community.
Yeah, I would echo all of that. I would probably add to it probably a more personal thing. When I met Dr. Greer and he introduced this concept, I was at a point in my career where I was somewhat disenchanted with the way in which we were addressing longstanding challenges in communities. Sadly, and I don't think I'm unique in this, individuals, when they go into their chosen career, they go in with a certain level of idealism, a certain level of excitement about what it is that they chose as their career. And unfortunately, I watched all too often the young public health practitioners that I would teach go out into the field and return in as short a time as 3 or 4 or 5 years. And the idealism in them had been beaten out by the realities, quote unquote, of the organization they went to work for, the systems and the models that they've been told are supposed to work. And so I didn't want to become another casualty of that. And so I met Dr. Greer, fortunately, at just the right time. He put this challenge in front of us, and I thought it was an opportunity for me to finally put my money where my mouth was. I had a mentor many moons ago. I went to his retirement and I was like, wow, you did a great job. It's incredible. He said, Luther, I worked 30 plus years in a community that was, poor and underserved and deprived. 30 years later, I go to that community and it looks like I never did anything because it still looks the same. In some cases, it looks worse. And he was like, that's because I gained a tremendous amount of success with very little solutions. And so I took from that there needs to be a greater emphasis and a greater focus on solutions over success. Success is personal. It's individual. It's about you. Solutions are about everyone else. And so there's a certain, each year I try to come up with a way to define what I want to be that year. And this year I chose, I want to pursue what we do with a humble boldness. And the humble boldness is, the humble is not about you. And the boldness is about not just simply doing just enough. And I think if we can instill that, and not only the students that we teach, but also the people who come to work for us, the way in which we work, I think that, that will be, the true benefit that we offer, not only for the community, but for each and every person who comes to work with us.
Lou and I were, even though he's from an island, it's called the Bronx. And I'm from an island, but that was in the Caribbean. I'm Cuban American, is that we were both brought up in Catholic education, which is one of the reasons my penmanship is so bad, because my hand's been crippled by the ruler from the nuns when I was growing up. But we were taught very, very, very much about humility and social justice. And that is what drives us. We have been lucky enough. Lou and I are both, I guess, second generation college, right? Are you, Lou? I'm second generation college.
Uh-huh.
And so we came from very humble backgrounds. And we've been giving these opportunities that we've done all very well. My two kids have graduated college without debt. That was one of the biggest things I wanted to do. Why can't we offer that to others? And as we do this pipeline program, we're bringing in, the reason we want to get the first gen students, the experience we had is many times in this country, we throw away talent. But that first generation college graduate is the key of that family for future wealth. Whether, I'm not talking Bill Gates wealth. I mean, I'd like to talk Bill Gates wealth, but the fact is that they might own a home. Maybe they have it to the situation where their children go through college and graduate without debt, as we see that burden going on right now. We really want to leave a lasting impact, and we want to bring all our resources together. And by the way, folks, this is the appetizer. You need to join us for our town hall meeting to hear all the other stuff that we're doing that's really cutting edge, innovative, and we need your help. We need your help and your advice and your support. We want to really make it so that everything that happens at Roseman, the world knows. We don't want to be the Stanford of Nevada. We want Stanford to be the Roseman of California.
Exactly.
We'd like their football players, though.
Wonderful. Are there any other questions? I'm going to post quick in the Q&A. And if not, I want to thank Dr. Greer and Dr. Brewster for a fantastic presentation. Thank you so much. That was really informative. And I will say, I'll speak on behalf of everyone that I think we're all looking forward to the town hall. If this was the appetizer, certainly looking forward to the full course.
And I just want to say one thing before we get off.
Mm-hmm.
Happy birthday, Brenda.
That's right. Happy birthday.
Thank you so much. 29 again. I appreciate it. With that, thank you everyone for participating. We appreciate it. You will, because you did register, we will send you the PDF of the slides and the video link to the recording. With that, thank you so much to everyone. Have a fantastic evening.
Thank you, Brenda.
Thank you.
Good night.